Good morning, gentlemen. It's about time to start the second session. In this session, we're focusing on alternative arterial conduits and innovative technique and best strategy for the harvesting technique. To start with, famous Professor James Taturis from Australia, he's going to talk about radial artery, a time-proven excellent conduit. James, please.
Thank you very much. It's a great pleasure to be here. Just to put this into context, I would remind you that coronary artery surgery is still the commonest operation that we all do, and presumably become more common as time goes on. And the second is, I think there's no doubt that multiple arterial grafts do confer a long-term advantage, and the easiest second graft to do is the radial artery graft. So that's the context, so I have no disclosures. So the radial artery was introduced almost 50 years ago by Carpentier, and then reintroduced about 25 years ago. And since we took that up quite strongly, and we have an experience at the University of Melbourne of over 20,000 cases where a radial artery has been used, and about a third of those we actually use bilateral radial arteries, although not so much these days with radial artery PCI. Now there's a lot of evidence in the literature that a radial artery is better than a saphenous vein graft, particularly this publication of randomized trials in the New England Journal a year and a half ago. So I think there's no doubt the radial is better than the saphenous vein. There's a lot of controversy that whether the radial is as good as or better than the right internal thoracic artery, and I think that's not a very important issue. I think they're not in competition. They're really grafts that can be used in conjunction with each other. So to the radial artery itself, it is a long vessel, reaches most places. It is very robust, very easy to use. There's two of them for most people, and they're very versatile. And as you can see, the bottom panel, the wounds heal very well indeed. You don't have the same problem with the healing forearm as you do with legs. So here's a comparison of the internal thoracic artery on the left and the radial on the right, and you can see it's an excellent length and about double the diameter. So it's a very easy conduit to use, and particularly to harvest. So some basic rules. So I think the idea of this talk is really to provide some pragmatic things for those of you that don't use radial arteries. And if I can make one plea, and that's for the more senior members to get their young fellows to go to a place where they do radials for a week or two and learn and see how they're done. But essentially, you'd use it just like a vein graft, harvest like a vein graft. Spasm prophylaxis is very important. Avoidance of competitive flow is also important by using it to tightly stenosed right coronary lesions and at least moderately stenosed circumflex lesions, as we discussed this morning. And we avoid using the radial that's been instrumented for at least 3 months. It's important to conduct the Allen's test. You can see on the top panel the waveform on the pulse oximeter on the index finger. The middle panel, where both are radial and ulnar are occluded with a flat line, and then when the ulnar is released with the waveform coming through to the index finger, and we take anything less than 10 seconds as being quite acceptable, and that's the case in about 90% of cases. So we normally take it open because we have residents, and it's hard to teach endoscopic techniques in the 6 months that they're there. So it's basically clip and cut technology. So that's very effective. And essentially the radial artery can be exposed. It looks like a big wound there, but don't figure this is about 100 times magnification. So those individual branches can be clipped and cut. Alternatively, we use a harmonic scalpel either to individual branches, and that's very effective and a much more rapid way of doing the operation. Or alternatively, you can just go down the sides of the radial artery and just take all the tissues together en masse. So it's a very effective way of dealing with it. Proximally, the veins are identified and divided between clips, as you can see, and we always identify the ulnar artery. You can see it's much bigger to make sure that's intact and not damaged at all. So we always use anti-spasm prophylaxis with intraluminal papaverine and let the artery beat on itself over a period of time. It's a nice vessel to use. It's quite wide. It's very flexible, and it's easy to handle. So it's shaped exactly as you would with a vein graft. So you can see it's got a nice lumen, and nice wall, and when you open it up, it's like a vein graft. It's about 6 or so millimeters in open splayed diameter. So it's a very nice conduit. It's always thicker and much more muscular than an internal thoracic artery, and that's why the anti-spasm prophylaxis is even more important with the radial artery than even with the mammary. It's a good size match for all the distal vessels. Here it is lined up with the right coronary artery, distal right coronary artery, and the right panel with the circumflex, so it's a very good size match. So we perform the anastomosis just as you would with a vein graft, whatever your method is, but you can sort of see the radial artery, because it's got a slightly thickened wall, just sits there opened out, and in fact it's much easier to use than a vein graft. So here's anastomosis to the distal right coronary artery beyond the crux, and again you can see the radial artery just sits there, and it's quite straightforward to use. Anastomosis of the radial artery to the posterior descending coronary artery. This is one particular technique that we use, but you can use whatever your favorite technique is. But again, to make the point that it's an easy graft to use, and it just sits there open, that the assistant doesn't actually have to keep it open for you to place your sutures in. So this is grafting to the circumflex, and we prefer a forehand continuous technique, and the radial artery sits there and is very easy to use. Proximally, you can see that it's about 7 or 8 millimeters when it's opened out. We use a 3.5 millimeter opening in the aorta, and again, we would perform the anastomosis exactly as you would with a vein graft. So there's nothing special about it, and the artery sits very nicely. Just to show you a similar sort of proximal technique, the actual artery sits there. We make it about 25% larger hood than the opening to make sure that there's a large pouting anastomosis. So it looks quite large here, but it makes a large pouting anastomosis. If the radial artery is small, then we use a smaller, like in a female, we use a smaller 2.8 millimeter punch for the proximal aorta. And again, you can see that the proximal anastomosis is almost 1 centimeter wide. The radial artery sits well, and it avoids kinking, unlike vein grafts that do kink. It is unusual for a radial artery to kink. And here's one that's been placed sequentially to the posterior descending coronary artery, and then goes on to the left ventricular or posterolateral branch because of its great length. The radial is very versatile and it's very easy to use to the circumflex artery. And again, proximally, we perform the anastomosis in the same way as you would with a vein graft. So there's nothing special. I think that's what I'm just trying to emphasize, that if you can do a vein graft, which we all do, then there's no reason why you can't place a radial artery to the circumflex. And here's the completed anastomosis. You can sort of see it's almost a centimetre across. So we use a 3.5 millimetre punch to do that proximal anastomosis. And here's a radial running to the circumflex on the top and to the posterior descending on the bottom in bilateral radials. The pleasing results are that long-term the angiographic appearance is terrific with no evidence of atheroma. More specifically, the radial is excellent conduit to use for sequential grafting. And again, because of the slightly thickened wall, it just sits there. So when you do open it for a sequential anastomosis, the opening in the radial artery just sits there and pouts, and again, it's very straightforward to use. So we do sequential grafts in about 15% of the patients, but sometimes that's not possible, and so we tend to use smaller, either liter radial grafts or little baby wire grafts. When we have a diagonal stenosis with a diagonal that's very lateral, so you can't do a sequential liter to diagonal, we often use a small segment of radial artery to perform a baby wire graft, or when there are parallel diagonals, but it excludes you from doing a sequential graft, then again, a small baby Y with the distal end of the internal thoracic artery or a radial is excellent, as shown here. Unfortunately, I can't use a pointer, but you can sort of see how convenient it is to use a small Y graft. So we tend to use little baby Y grafts quite a lot, particularly when a sequential lie is not ideal. So by using little baby Y grafts, you can actually do the distal anastomosis to wherever you wish on the coronary vessel and then join them up. Often we use the primary graft to the more proximal marginal and the baby Y to the more distal one, as shown here. But alternatively, you can use the primary graft to the more distal and a short limb to the more proximal one. So it doesn't really matter. The main principle is that you actually graft the best part of the circumflex marginal arteries that you wish. And you can see in this construction, it would be very difficult to create a sequential anastomosis on those two circumflex marginals, whereas that situation is solved by a baby wire graft. Similarly, on the right side, a posterior descending graft is created, and then a smaller segment, a shorter segment of a baby wire graft is constructed, and unfortunately, you can see the radial running to the inferior posterior descending and a Y segment running to the left ventricular branch. So radials are very, very easy to use in these circumstances. And here's the construction of the proximal Y anastomosis, the main trunk going to the posterior descending and the segment on the right running to the left ventricular branch, and that anastomosis is constructed near the acute margin, and it's very straightforward, very easy to do. Similarly, with baby wire grafts on the circumflex side, and you can see the Y anastomosis at the top of the screen, and you can inspect that and check it, and here's the postoperative angiogram. So the patency and clinical results are well publicized. The radial artery given to the same artery in the same situation as the same patency as the internal thoracic artery. So in an experience of over about 8,000 graft angiograms with about 4,000 arterial graft angiograms, the patency of the LITA, the RITA, and the radial to the LAD is identical. The patency of the LITA, RITA, and the radial to the marginals identical, and also the patency to the right coronary system is good, but not as good as the other two. So we have found in the long term, the patencies have been excellent and far superior to saphenous vein grafts. So rather than use a saphenous vein graft, please use a radial artery. And that's been shown repeatedly by randomized trials from Melbourne in the RAPCO trial, from Toronto by Steve Freems in the RAPS trial, and also in the meta-analysis of randomized trials by Gordino, showing much, much better results for radial artery, both in patency, but also in terms of long-term survival. Now, we have good 10-year data of patency and survival. This is 20-year data published in JACC by Mauro Gordino, showing that the radial artery patency at 20 years is about 87%. What we found when we've done repeated angiograms over a period of time, mainly for new symptoms, often associated with aortic stenosis, is that once the radial artery is established and there's no technical problem, then it stays patent forever. I think that's the key thing. The arterial grafts, if there's no technical or competitive problem at the start, they do stay patent forever, and they're certainly associated with much better survival. And there's a lot of stuff in the literature to indicate that, including the randomized comparison published in the New England Journal. So, as I said at the start, there's no competition, I think, between the right internal thoracic artery and the radial artery. I think they should be used in conjunction, but the easiest second graft, in my view, is the radial. So what do? We routinely use it as a second or third graft of choice. It's especially useful in obese, insulin-dependent patients, reoperations where vein grafts and other grafts have been used, or the legs are no good. And it's certainly very useful for older patients to ambulate quickly. So a couple of philosophical things at the end, as stated by Tony Calafiore. Spending 30 minutes extra, why is that such a difficult problem for surgeons? And also the fact that there's never been any study that's shown better patencies for vein grafts of arterial grafts, nor better survival. So arterial grafts have always been associated with better survival. Half an hour extra adds a few more years to a patient's life. And we'll see in talks tomorrow that for every 100 patients we operate, 10 more patients will be alive at 10 years and 13 more at 15 years. So a second or third arterial graft should be considered for everybody. Thank you.
It's always elegant lecture. Just a couple of two things in a technical aspect I want to just clear it. The number one, it's more arterial graft nowadays treated with so-called skeletonized technique. Internal mammary reduce the sternal ischemia, which is important. For my part, gastroepiploic, I'll tell you later, but that makes graft significantly larger. But in a radial artery, similar muscular artery, is there any role skeletonization makes something better or harmful? That's the first question.
Thank you. We totally agree. We use skeletonized internal thoracic arteries all the time, and they do make them longer, wider, and less sternal infection. With the radials, we don't routinely skeletonize them, but occasionally, if it looks a bit short, if you want extra length, yes, I think skeletonization does. I don't know if it increases diameter, but it certainly increases length by between 1 and 3 centimeters. So occasionally we will skeletonize it specifically, and we tend to do that after it's harvested rather than at the time of harvesting, correct.
At the initial revival of radial arteries from other facility, there was some emphasis to use intraoperative and post-operative, let's say, calcium channel blocker from American or some other. What your vast amount of experience, do you still need some additional drug compared to ITA-only patient?
We always have used and will continue to use both intraoperative antispasm treatment with papaverine intraluminal. We use nitroglycerin intravenously, and we use long-term calcium channel blockers for 6 months.
I see.
And that's for 2 reasons. One, these 4,000 arterial graft angiograms, we've seen it 1 or 2 months afterwards, sometimes spasm, and also in the meta-analysis by Gordino, published in New England Journal, one of the key findings was patients that had long-term calcium channel blockers actually did better.
Thank you very much, sir. Dr. Natapam?
Professor Tatulis, I would like to ask your opinion about, is there any difference between you use radial artery directly from aorta or composite way? Which way is better?
In our experience, about nearly 80% come directly from the aorta. We don't use so many, only about 10% from the LITA. I don't know which is better. I think the graft angiogram results have been very good both ways. I think the important is to avoid, with the radial, moderate stenosis if you can, but as I said this morning, it's not 0 or 100%, it's just a bit less. But I think either way, whatever's most practical for the patient.
Good morning, sir. I have 2 questions for you. First is, do you do a radial artery Doppler for all the patients preoperatively? And is there any cutoff size for the radial artery diameter that below this diameter I'm not going to use this radial artery? You use radial artery for all patients immaterial of the size?
Yes, we use plethysmograph, as I showed, for everybody. Ultrasound we use when we think there's a lot of calcification or we can't feel the pulse all that well. And yes, we would not use a radial artery that was small, like less than 2 millimeters in diameter distally. That sometimes is not all or none, particularly in small women. But yes, we avoid very small radial arteries. So we're not totally wedded to the technique. We do use saphenous veins from time to time as well.
Yeah. And second thing, do you prefer an open method of radial artery harvesting or endoscopic?
We routinely use open, mainly because we're university teaching hospitals, and to do it closed requires a specialist skill which takes many months or years to develop, and we don't have that luxury, but we do find that they heal very well. But that is a very good technique as well for those that do it all the time.
And third thing, just a suggestion. We have been using radial arteries for the last 15 years, and we have found that use of phenoxybenzamin for a radial artery instead of papaverine makes the artery dilate more and has less prone for spasms.
Yes,
Thoughts about it?
I'm familiar with phenoxybenzamin. We don't have it available, but I'm certainly familiar with its very excellent, potent, and long-term effects. So I think it's an excellent way to go.
Yeah, thank you.
One question before you leave. You have mentioned about the calcification of the radial artery you like to discard. How much calcification? Sometimes we encounter like a scatter calcification here and there. Would you accept those kind of calcification, or would you discard them?
Yes, I think patchy calcification is predominantly in the media. It's not in the intima. I think the main problem of calcification is creating a watertight or blood-tight distal anastomosis. So I think that's the technical issue there. So if you can create the hood of the distal anastomosis where there's no calcification and you can do a blood-tight anastomosis, that's fine. And the other contraindication is whether the calcification stops the graft from sitting nicely, and I think that's a subjective thing. So we accept mild calcification. Yeah.
Thank you very much.
Thank you.
The next speaker will be our chairman here, Dr. Ascvts. He's going to give a talk about gastroepiploic arteries, a Cinderella arterial graft.
Good morning, gentlemen. I'm extremely honored to be invited here to give a talk about the gastroepiploic artery, which has been presented as a forgotten graft or underestimated graft in a previous meeting. But President Dr. Tavisa gave me the name Cinderella graft. So I'm trying to make a presentation in the Cinderella fashion. So I'm going to be a storyteller of this girl. It's named Gia. Once upon a time, there was an arterial graft named Gia. So anatomically, as you know, the right gastroepiploic, the largest branch of the stomach, and it, from the previous extensive study, the right gastroepiploic reached more than half of the greater curvature of the stomach in 95%. And it reached 2/3 of greater curvature in 34%. This is actually big artery. But there's previous histologic study by microscope. It's a Netherlands group, Dr. Van Son's group, compared various arterial conduit together with coronary artery, left anterior descending. As you see in the chart, table in the right, in contrast to radial artery having significantly thicker muscular media, LAD, ITA, and the gastroepiploic having a similar thickness of the artery. Only ITA has a multiple layer of elastic lamella, which other artery, the basically muscular artery, including left anterior descending. Our group presented in a previous meeting that segmental difference was observed in vasoreactivity of gastroepiploic artery. We have shown more vascular reactivity in a very distal part of the gastroepiploic artery. And vasoreactivity is a key thing in the muscular artery, including gastroepiploic and radial artery. So in terms of this configuration, we always harvest. It is important to harvest very proximal part of pylorus, close to pylorus, mid part, and trying to trim off the distal part if it is too small or reactive. Why the gastroepiploic is forgotten? In earlier work by Suma or other originator like Dr. Pim, I think rate patency was not as good as saphenous vein initially. But we have to keep in mind that Dr. Suma's initial report was a result of angiogram of a problematic patient who recurs the symptom. So this was, I think, the part of the reason of underestimation. But he also demonstrated atherosclerosis in the late phase very rare, and anastomotic stenosis is less critical stenosis, causing competition, now we know. These things were the problem. So from these earlier work, we now know to choose a grafting target with a severe stenosis or totally occluded vessel, and prepared GA conduit maximally dilated state, which is very important. And the earlier study by Greener, DiMauro, did study, GA didn't show good outcome compared to saphenous vein, but you keep in mind that this study was done for indiscriminate use for the right coronary artery region, which include a lot of mild to moderate stenosis. That cannot be the reason GA should be abandoned. So now we know we have very severe stenosis, less than 1 millimeter, or very tight stenosis is a still good candidate for this arterial conduit. So now everybody go back to Cinderella story. I think Cinderella had a magic, special magic to make Gia a beautiful princess. What is the secret? What is the special magic for the Gia? I think the answer is the skeletonization. We have done a skeletonization of internal thoracic artery to minimize the sternal damage, subsequently reduce the risk of sternal wound complication. But in terms of GA preparation, harmonic skeletonization really makes difference in terms of size of lumen, also length of conduit. The first report of skeletonized GA was from Monaco. Dr. Gabriel Dotto, together with Dr. Vincent Dorr, they reported significant large conduit at good preparation of skeletonization. That was 1998. I personally introduced that more simple and safe technique using harmonic scalpel, which ultrasound technique is actually this device originally designed for abdominal surgery. So it is ideal to take care of very fragile, tiny branches of the gastroepiploic. We were surprised, simply, with the size of conduit, also the graft patency initial experience. So further in my facility, that's Dr. Fung from Vietnam and also Dr. Kinoshita extensively checked that histomorphologic aspect of skeletonized GA, which we found in the right table. We use a single target to the PDA, or sometimes other branch of, atrioventricular branch, or sometimes go to the circumflex circulation. I want you to take a look at this here. Internal luminal diameter to reach the circumflex area, still 3.9. That's the median size of the diameter. This is significant. Although there is some individual difference, the individual difference of size have a median, almost 4 millimeter internal diameter. And you see the flow by transit time flow measurement. There was significant large capacity, I think sufficient capacity to give a myocardium. So in a skeletonized format, Suzuki of our group, also Korean Dr. Jones group, we showed very promising outcome. We carefully select the proper target, which the RCA having subcritical stenosis. So skeletonization really makes difference. Not only just like ITA, GA specifically benefit from skeletonization from it. And in recent paper from the Greener, really showing the better outcome in very long term. Also the last year, Giuseppe Tavira in Europe, who showed excellent outcome with the 3 inside to skeletonized. No, I'm not certain this is skeletonized. But you see the one thing is MI-free ratio is only 7.8%, although they have a very younger group of patients. Why does skeletonization work for GA? Nobody knows completely. However, the one speculation from this group is skeletonization really makes sympathetic denervation, which is a strong constricting factor to the arterial graft of this type. So in a Cinderella story, there must be a key word, the glass shoe. What's the glass shoe for GIA? Glass shoe is a key for this story, Cinderella story. I think this is inferior and inferior-posterior wall, and inferior-lateral wall of the heart. Because this is the exact area inside the ITA does not reach with adequate luminal size. So GA can be liberally used for the single target like a PDA, or maybe 2 sequential grafts in the right circulation, or sometimes go beyond the circumflex area with adequate size of lumen, sufficient size of lumen. But everybody should keep in mind, this is a famous article from, I think it's somewhere, Israel or somewhere. But this is, I think, we agree, some occasional closure of the limb in a composite graft. Composite graft, even though they're affected by stenosis of target or technical complexity, but it is generally, I think, more unpredictable compared to only inside the configuration. So in that matter, we are not using routinely multiple composite grafting. So if you use in situ format with ITA grafting, the left one is the most commonly used probably. Later to LAD, the right via the transverse sinus to deploy the obtuse marginal or maybe diagonal, which is important. But in this configuration, the weakness is the right ITA occasionally does not reach the distal part of circumflex. So that is the area GA is really good if you can take nice skeletonized gastroepiploic. In the central part, actually in my previous facility, I have employed this strategy for 90% of multivessel in situ grafting. Right ITA goes to LAD. Left ITA can be more liberally used for diagonal or maybe more than 2 circumflex. Gastroepiploic can be covered, rest of area. If you really want to avoid the 2 mammary use for extremely sick, diabetic, obese, so we can preserve the one right ITA not to be harvested. We can use some sequential technique with the GA and the left ITA. That is occasionally performed by practice. So that's all arterial in situ non-composite strategy. This is my previous facility. So it's about 61% of RCA region was grafted by the gastroepiploic artery, which is the skeletonized gastroepiploic artery. 36.4% of gastroepiploic artery was used in sequential fashion for more than 2 target sites, maximally 4 vessels. One patient in the LAD was, I think, with conduit deficit. So in outcome, we followed in an outpatient clinic, which showed 94% of 73 months. In 8 years, we have a 90.2% of a patency rate in the late, which could be better than conventional non-skeletonized technique. It is easy like this. In a technical aspect, I'm going to talk tomorrow. Anastomosis and harvesting. This is a PDA and the one terminal branch of the circumflex. This is a recent picture. You see huge artery giving a supplied broad area of inferior wall. This is total arterial revascularization, 3 in situ for configuration. This huge artery having a sufficient luminal diameter for the circumflex. So 9 years later, it's still pristine compared to very diseased right coronary artery. So the point is 3 blood flow inflow source would be provided, aortic non-touch without making complex Y composite. Inferior posterior, the key, glass shoe for the GA. 3 skeletonized in situ. So in summary, GA has the potential to make progress for CABG strategy. Special magic was the skeletonization. And the glass shoe is the inferior lateral wall, which other step-sister foot cannot go. Thank you very much.
Thank you very much. That was a very extensive experience on the gastroepiploic arteries. I just wonder, when you do the sequential graft of gastroepiploic arteries to the inferior wall lesions, the arteries, how do you select the sequence of the anastomosis? Let's say PDA, posterolateral branch, sometimes the PDA is bigger or posterolateral branch is smaller. How do you make it, do you have any principle in making the sequence? Which one should be side to side, which one should be end to side?
Thank you for an important question. First of all, we put, let's say, the PDA and posterior left ventricular branch. If there is a good connection, I would put the best part in this system. However, let's say, bifurcating point of the distal right, there is a separate occlusion. There is a good vessel, both. I do put 2 anastomosis. In terms of technical aspect, we can make so-called diamond anastomosis, crossing like this, because we have a luxury having a big internal luminal diameter, sometimes 5 to 6 millimeter. So pretty much just like radial or even for the saphenous vein, I usually make 5 to 6 millimeter of hole in a target and arterial conduit. We make maybe 8 to 9 bites all around with 7/0 or even 8/0 prodding. That is not a problem for most of the surgeons, I guess.
Yes.
My question is that if you want, suppose I want to do a good result as Professor did, I think I read some papers like you have to have the size of the GA not to be less than 1.5 millimeter at least. If it's smaller than that, it have a high chance of failure. So is it important that we should check up preoperatively, like a CTA or something, to check your GA first before you decided to use it or not?
Thank you for a very important question. I would say that we will never know the real potential size of GA GA can change the diameter by diet, surgical manipulation, or any type of stimuli. So we first take a look at the CT angiogram. It is maximally dilated. We're not certain. Histamine acting differently to the ITA to GA. GA is dilated. ITA would be shrink. So we will never know. So we just take a look and just prepare with external application of a papaverine soaked sponge. So we are not certain. And earlier paper by Dr. Suma and Dr. Pim, they said average 1.25 millimeter in diameter. I've never seen that in a skeletonized fashion. So I cannot say exactly 100% for your question, but I caution every surgeon, GA cannot be underestimated with proper preparation with a dilative agent.
The second question is that, do you think that is important about the sequence of conduit harvesting? Suppose you want to do bilateral ITA and you want to use GA, which is maybe GA is more spastic, right? So should we start by harvesting GA first, or we should harvest IMA first to get a better result?
Thank you for a practical question. That's, we take a look at the GA at the beginning, after sternotomy, always, before taking down the mammary. If GA is individually too small, let's say really tiny, and the left GA is pretty big, or maybe some arteriomatous plaque, which is very, very rare, but present sometimes, then we go ahead and take another maybe saphenous vein or radial artery. So we take down the mammary, two mammary. If you take down two mammary, then go to the GA. Oh, GA is not good. I said, don't underestimate. However, some arteriomatous plaque, maybe 2%, that we waste time. We cannot take 2, 3 inside the artery simultaneously, except for some expert specialists. That may be some weak point. Thank you.
Go ahead.
Sorry, good morning. Just one practical question. If you use for the 3 main vessels, the 3 arteries, 2 mammaries and the GIA, the first anastomosis you do is with the GIA to the posterior lateral, or?
I think that can be done any target. However, most ischemic area usually we do, but I think that LAD, maybe right ITA or left ITA to be done first.
I was speaking in on-pump surgery. Just if you go with your right mammary by the transverse sinus to the marginal of the circumflex, after that it's difficult to move the heart.
That's right.
Then you would begin with a gastroepiploic, not to...
Okay, gastroepiploic, you bring the heart, rotate, tilted towards the right shoulder, which would not injure that right ITA.
Okay, then it's not so important for you the choose of the first anastomosis, is it?
We should really take care for later to LAD. You will bring the displace. We may just pull that anastomosis. That might be some little trick. So gastroepiploic, it's more. I think more importantly, we have sufficient length to the anastomosis also. If too short, it's going to be no good for this.
Okay.
But thank you for the practical question.
No, thank you.
You will use as a free graft?
I rarely use a free graft. There's some other group having some experience, but GA usually having 23 to 25 centimeter length in a specimen. So I'm pretty sure it can be used free graft. But inside the graft is adequately covered. I think it's a very rare occasion we need to make it to the free.
Yes, the last question.
As we do sequential grafts,
Yes.
we always try to do the last graft should be a bigger caliber than the earlier graft. So
You mean a last point of the
point of the graft.
terminal point of the anastomosis you mentioned? Okay.
Yeah. So doing rhomboid or not rhomboid, by side and then sequence. If you do this with the gastroepiploic artery, how you do if the PDA is a bigger one and the PLB is small, how you do it? Or sometimes, second question, have you ever done this gastroepiploic artery to the right RCA instead of PDA?
Distal RCA, not a branch, you mean?
Yeah.
Okay. First of all, I think I understand your policy, but I think more importantly, terminal anastomosis of branch should have very tight stenosis, which make sequential graft open. Adequate size, not the biggest side, adequate side with a very critical stenosis, which is important to make other side branches open. That's my strategy. Distal RCA could be a good target if there is no adequate size of PDA and other branches. Maybe we can discuss later.
Thank you for the impressive presentation. My question is, I have sometimes confused about a mild stenosis and like a diffuse, like coronary artery is enough severe to use a gastroepiploic artery or not. So like a 75% stenosis tandem area or something like that. Do you have any recommendation to judge the severity of the right coronary artery stenosis is enough to use like a gastroepiploic artery?
That's an open question, but as I showed you in the previous slide, 1.0, 1.1 minimal luminal diameter on the right coronary artery has been suggested by David Greener's group, and all the other from Calafiore and Di Mauro's group, so at less than 80%. But that does not necessarily mean that 70% of stenosis is all occluded. No, that is some sort of marginal line. We still need more cases investigation. But the one thing I want to make, these data are not skeletonized GA. I'm not certain how skeletonized GA counteract with this more milder stenosis. I'm very cautious to put this tight stenosis, but I think it's time is. Thank you very much.
Yeah, thank you very much.
Thank you. I think we have to move on.
Yeah, we can discuss it later.
Okay. Next, thank you, Dr. Asai. The next speaker will be also from Japan. Professor Arai is going to talk about innovative surgical approach for coronary osteostenosis. Dr. Arai.
It's my great pleasure and honor to be invited as one of the speakers in this great meeting, Ascvts. So the title of my talk is Innovative Surgical Approach for Coronary Osteostenosis. As you know, as a surgical revascularization, CABG is a gold standard, especially using arterial graft is a gold standard. But I'd rather speak regarding patchplasty technique for the coronary ostial stenosis. It's an alternative method for the surgical revascularization. So the first report of coronary artery pericardial patchplasty was 1961 by Swedish cardiac surgeon Senning. This was before the era of CABG, and followed by Dr. Effera from Cleveland Clinic. He performed the left main trunk patchplasty using saphenous vein graft January 1962. And then he performed many patients, but it was very difficult procedure. He did a midline stenotomy and considerable difficulty in visualizing the proximal left coronary artery. The graft reconstruction was best characterized as an acrobatic feat rather than a surgical procedure, high mortality rate. So how about the mortality? It's incredibly bad. So operative mortality for left main trunk was 44%. So almost half of the patients died after the procedure. And the total mortality was 25%. Why it was so bad at that moment? This is another paper from Zaviston. So this kind of complicated procedure at that era was required because the poor technology of the cardiopulmonary bypass and the cardioplegic was not satisfactory. So that was the reason of the very bad result of left main trunk patchplasty. So actually, late 1960s, almost at the same time of the moon landing, Dr. Favaloro published a series of the saphenous vein autograft replacement as a CABG procedure. And so we switched to the coronary vascular surgery, bypass surgery, instead of a patchplasty. So patchplasty was forgotten procedure at that time. But in 1983, there was one paper of the revival of left main trunk patchplasty by Dr. Hitchcock from Netherlands. The result was great. Using saphenous vein graft patch in 9 patients, operative mortality was 0%, and their approach was a posterior approach. So they approached from the posteriorly. And then Dr. Dion published this paper. He introduced the anterior approach. So he first used the saphenous vein patch, but then switched to the fresh autologous pericardial patch procedure. Another procedure, 1997, is a transpulmonary approach by Dr. Belmont group. Although they cut the pulmonary artery, the exposure looks very excellent. And later on, they published a long-term result of this procedure in 2010. Perioperative mortality was 1.1%, very satisfactory. And 5 and 10 years global survival was 95% and 80%. And repeat revascularization rate at 5 years was 12% and 10 years, 70%. Almost satisfactory result. And followed this technique, there's transaortic approach by Dr. Lisker. They used the internal mammary artery patch. But this approach is very reasonable, and my preferential approach, actually, was published in 1999. So this is a summary of the approach of left main trunk patch angioplasty. Left one is a posterior, the initial approach, and anterior approach, which was introduced by Dion, it is good. And transpulmonary approach, excellent exposure, and finally, transaortic approach. You can get real nice pictures and make easier patchplasty. So what is the outcomes of the patch material? So there's very limited report, but according to these review papers, the late stenosis using saphenous vein patch was 1.3%. When pericardial patch was used, especially by the glutaraldehyde, 6.3% of this rate stenosis. So what is the advantage and concern of the saphenous vein patch or pericardial patch? So saphenous vein graft, size and character allows simple creation of a funnel-shaped anastomosis. But the elasticity may bring about a tendency to dilatation, and smooth muscle cell migration and proliferation may result in accelerated intimal hyperplasia, leading to long-term restenosis. And pericardium, easily harvested and readily available, and allows for preservation of future conduit material. But lack of fibrinolytic properties may theoretically promote calcification and subsequent restenosis. But when you think about the, comparing to the CABG procedure, left main trunk patchplasty provides maybe ideal antegrade coronary perfusion. So in this slide, the A is a retrograde perfusion and C is an antegrade perfusion. So if you compare the head pressure, the antegrade perfusion provides much better perfusion for the coronary system. So if this is performed perfectly, the patchplasty might be better than CABG procedure. So if you look at the data of the syntax trials 10 years, comparing to the CABG and PCI, almost the same. Maybe this is some kind of limitation of the CABG, and also that there is a new nicely stent is coming, so maybe there might be no space for the patchplasty. Maybe we have to move to the stent procedure. And also the contraindication of this procedure is calcification, and if there is a multiple disease, vessel disease, not good for a candidate, and if the stenosis extending beyond the proximal LMT, it's not good. So again, we have to abandon, maybe we have to abandon this procedure. So what kind of patients are ideal candidates for surgical coronary osteoplasty? Is there any kind of the patient who got the benefit with this procedure or not? Yes, they exist. Takayasa arthritis. Takayasa arthritis. If the patient was Takayasa arthritis, okay, the lesion is specific to coronary ostium, usually. The distal coronary is not involved. But the problem is it frequently involves arch vessels, so you can't use pedicled IMA. And the aortic wall is thickened and friable, so it's quite difficult to establish AC bypass, especially the proximal anastomosis is quite difficult to establish. And strong inflammatory reaction. So if you perform a PCI for this kind of patient, frequently stenosis of the stent happens. So for this kind of patient, I think the left main trunk patchplasty is the ideal technique. I present two typical cases of my, which I operated. So case one is a 45-year-old female, Takayasa aortitis with severe aortic regurgitation. Ostium, the main trunk was a 90% stenosis, and right coronary is a 50% stenosis. And the surgical procedure is a aortic valve replacement in combination with bilateral coronary ostial angioplasty. But in this case, I used a superficial femoral artery patch. So I harvested a superficial femoral artery patch, and then that site was reconstructed by usual vascular processes, and made both coronary ostial patchplasty. And soon after the operation, there was really nice enlarged coronary ostium. And also, actually, I performed this operation more than 15 years ago. And after 15 years later, it shows no stenosis or kinking and no aneurysmal dilatation or calcification. So this procedure works. And the second case is a 37-year-old female, 22-year-old Takayasa aortitis, and she has ascending aortic aneurysm 46 millimeter and moderate severe AR, and left main trunk ostial 90% stenosis. So actually, there was a total occlusion of the left carotid artery, but if you look at the femoral artery, it was intact, and left main trunk was 90% osteostenosis. In this case, right coronary artery was intact. So I did aortic root reimplantation, David procedure, in combination of coronary ostial angioplasty using common femoral artery patch. So the diameter of the main trunk was only 1 millimeter. So I made an incision on the carrier patch, and the incision was extended to the ostium of the left main trunk. So enlarged the left main trunk like this. And also, I harvested the common femoral artery a piece of confemoral artery, and make a rectangular patch and anastomose to starting the distal left main trunk using a 7 monofilament stitches. And the handling of the femoral artery was really nice and easy to fit the coronary artery and also the aortic wall of the carrier patch. And finally, I cut the longitudinally and make a big rectangular patch like this. And then I made a real big anastomotic hole for the Valsalva graft of this patient. The 2 centimeter in the length and 1 centimeter in the width. And I started to anastomose to the vascular graft using a 7 monofilament stitches. And finally, the femoral artery patch was incorporated to the aortic root of the Valsalva graft. And I tried to make a kind of a protruding patch. And finally, to make like a curtain fold, it's overriding the left main trunk. It can prevent the kinking of the patch. And after the operation, real nice enlargement of the ostium was confirmed. So this is the pathological findings. So ascending aorta, it's very bad. Fibrous thickening, disruption of elastic fibers, and invasion of capillary vessel. But if you look at the femoral artery, almost nothing. It's not involved. So as a conclusion, coronary ostial patchplasty is an effective surgical strategy for a selected patient, only selected patient, of inflammatory arteritis such as Takayasu disease. And femoral artery might be an ideal patch material for a coronary osteoplasty in this kind of group of patients. Finally, we're going to organize the International Coronary Congress in this December in Tokyo, so please come and visit Tokyo after Tokyo Olympic Games. Thank you very much.
Dr. Arai, fantastic presentation. I just want to clarify that's a technical point. When you harvest a femoral artery, I think superficial femoral artery, it is going to be directly connect or just replace with a short segment of the graft?
Actually, maybe you can directly connect, but in this particular cases, we used a small piece of vascular graft, and so it's easy and guaranteed for the patency because a 10 millimeter diacron graft, it lasts long.
You think the femoral artery is better than the pericardial patch or some other synthetic patch?
Probably you have experience of using pericardial patch for the mitral valvuloplasty. So I have actually bad experience. Some patient, especially if the patient is young, even 5 years later, it's stiffened and calcified and degenerated. I think the same thing happens to the coronary artery. So I avoided to use a pericardial patch for this kind of patient. And for the femoral artery, it's easy to handle because if you make a rectangular patch, it makes still some kind of keeping this kind of shape, round shape. And it is easy to handle with and can be easily incorporated to the aortic wall, and also the fitting to the coronary artery is very, very nice. Because these kind of patients are relatively younger age of group.
You know, with all the 2 cases of your left main ostial lesions, it is pretty isolated, very thick,
Exactly.
like a bird beak appearance. But what about the other atherosclerotic disease, which may be just a few millimeters lesion or a little bit extended? Would you go ahead with this kind of procedure, or you would rather do a bypass?
Yeah, I think there's a potential of the future stenosis of the rest of the vessels. So I don't do this kind of procedure for the atherosclerotic patient. Only such a kind of inflammatory disease patient. Yeah, we have to precisely select the patient.
Some people did left main plasty plus Lima to LED. What do you think about that?
If you have a distal region of the IMA, the LED, it can be possible. So so you put the patch plastic for the LMT, and then got a nice flow to the circumference area. But for the left hand LED areas, you circulate by the bypass. It's okay. But if there's no stenosis for the left anterior descending artery, then you might lose the graft.
Any questions? Doctor, I just one more small. It's ostial stenosis usually have maybe fibrous and inflammatory tissue. You just cut it open.
Right.
Do you think you still have to take out some subintimal remain region? You put augment with the artery, but remaining area, that's cause of any later?
Yeah, it might cause. But if you touch it, it's
cause more
over.
reaction.
It's easily dissect and friable. Never touch that portion.
Dissection is a concern. Right. Thank you very much. It's okay. Thank you for your presentation. Thank you. Excellent. Last lecture from this session is Dr. Wirachai, co-moderator. Dr.
Thank you, Professor Asai. After following all the giants in coronary surgeries give the presentation, my talk is going to be very easy because you have talked them all. I just do some more repetitive presentation. You know, when my task is to see how to choose the conduit, different conduits in coronary artery disease, bypass. So there are four conduits that we commonly use is mammary artery, radial, saphenous vein, and gastroepiploic artery, which you have heard them all. But before you want to decide, I think you need to know the conduit, which one, how your conduit behave. What is the problem? What is the patency rate? What is the adverse effect from the harvesting? Is that difficult or easy to handle during anastomosis? Those are also involved. ITA, I'm not going to give you too much repetition of what people have said. Mammary artery is probably the best graft in the world for coronary artery, especially to the LED. And it does have a very good intraelastic laminas and less media. That's why it might not cause any more spasm. And it will also produce nitric oxide. That's one of the best characteristics of the mammary arteries. That's why you have a very good patency rate compared to the saphenous vein graft. So with this, I think with this background, I think we all agree that Lima to LED is a must. Maybe either Rima or Lima to LED is probably the best. So what is the question is, what is the second graft? It has been debated for several decades. We're still here. We haven't had a very good conclusion yet. What is the probability of graft patency? You know that Lima is the best. Rima is secondary to that, then following radial artery and saphenous vein graft. But when you use the mammary artery, it is not always good to every coronary territory. It depends on the territory. If you go to LED, it's the best. When you go to the right, it's the worst. But left territory, it's still okay. Circumflex, obtuse margin, it's still okay. So with all these good characteristics, it has been proved that bilateral mammary is probably better over more than 2 decades ago. And there are also several observational studies, several meta-analyses also favor bilateral mammary artery over single mammary artery for survival, for MACE, for everything. But, but those are not randomized studies. The only randomized study with a large number of sample is the Aats trial. We have about over 3,000 cases divided into single and bilateral mammary arteries. And we found out that at 10 years, it's not very, as we expected from the previous observational studies that we have seen. From the intention to treat at 10 years, there is not really a significant difference between the two groups compared to mortality, compared to the date of MACE at this time. But if you look at the intention to treat, there is a significant difference between of bilateral mammary compared to the single mammary arteries. So the reason for not much significant, maybe our medication is so good, and lots of them use radial arteries, and there's a lot of crossover. I think but the most important thing is probably technical skill, the patient surgeon's volume. If you look at just the volume of the patient surgeons, if you use the highest volume surgeon, the single mammary artery and bilateral mammary artery, the mortality rate from bilateral mammary artery is significantly less than the single mammary artery at 10 years. And also, another thing that is we want to avoid is the sternum wound problem. We know that, with the bilateral mammary artery, there's increased sternum wound problems. But that's only with the pedicle graft, with non-skeletonized group. But if you skeletonize, the incidence of sternal wound problem is almost the same as the single mammary arteries. So what is so good about skeletonized technique? It does just like a previous speaker has told us that the skeletonized technique has much better, bigger size of arteries and much better flow, and devascularize the sternum much less. So you have a less chance of getting sternal wound problems. When you're thinking of using the bilateral mammary arteries or multiple arterial graft, which is the best configuration? There are several configurations in situ, or using the gastroepiploic bilateral mammary without a composite, or use the composite graft, Y graft, whatever. There are a few studies coming out. Gilnor's group has also published this paper and found out that at 3 years, 4 years, there is no difference really in the difference between bilateral and single bilateral mammary on different single configuration, whether you use Y graft or the in situ graft. But the Y graft does give you more flexibility, more distal anastomosis, and this paper shows that 7 years, bilateral mammary with Y graft does have a lower rate of MACE. But Calafiori's group show no difference at 20 years with the Y graft or the in situ grafts. So we are settled on that. But the problem that we have mentioned earlier is the moderate lesion. When you graft on a moderate lesion, you got a competitive flow. Competitive flow is the major cause of graft failure. That's why it happened to radial arteries, happened to gastroepiploic artery, until we realize that when you graft to moderate lesion, it is bad. So if we avoid that, we got a much better patency rate after 10 years. So competitive flow for mammary artery to different targets are different. If you put in the LAD and non-LAD, they are different. This is from Cleveland Clinic's data. You can notice that even the LAD, if you graft to the 40 or 50% lesion, the patency rate is still over 90% at 10 years. Another thing that we have to worry about is the diabetic patients. Pascas has published a paper, a report that even bilateral mammary artery in diabetic patients At 8 years, survival rate is much better with bilateral mammary than the single mammary artery, provided that you use skeletonization. But one thing that people do not talk about that much is coronary bypass in renal failure. Right now, we're seeing increasing number of ischemic heart disease in patients with dialysis and all that kind of thing. We found out that the patient who is hemodialysis dependent renal dysfunction, ITA also, when compared to saphenous vein graft, is associated with lower risk of death, lower risk of composite outcome. One thing that happened is when you use the mammary artery on the ipsilateral side of the, with the AV fistula on that side, there is a significant lower velocity when you start running the hemodialysis machine. So that's kind of bothersome. In Cordinos has reported this kind of thing with when they start using the hemodialysis machine, the velocity has dropped down, and the patient has hypokinesia on the on the echocardiogram, and also some people presented with angina. So that's kind of worrisome. But what does it really cause any long-term result? The Japanese group has published paper on this 155 hemodialysis patient, 108 patient with ipsilateral ITA with AV fistula, and 47 with contralateral. Over 16 years, there's not much difference between the survival rate and also freedom from MACE at all. So it means that, you know, you probably have to, you can use the ipsilateral mammary artery, but I think you have to be cautious about if the flow on the AV fistula is really high flow, it can really lower the flow to the mammary artery, it can cause ischemia. So the bilateral mammary artery summary is you should skeletonize. Configuration doesn't make any difference. I think it depends on the skill of technical skill more than anything else. And the, you have to be careful about the diabetic and the obese patient. Radial artery, I think Professor Tatoulis has mentioned about all these things. The radial artery is probably inferior to Lima, but it's probably better than saphenous vein graft. And from the radial database, at 9 years, you found out that mammary radial artery is better than saphenous vein graft on the graft failure, on death, myocardial infarction, and revascularization rate. So this is also the long-term result of the single institution. Over 13 years, you got about more than 80% patency rate. But the radial artery, just like any other arterial graft, it depends on the target vessels. The LED is probably the best, but when you go to the circumflex to the right, the patency rate seems to decrease. And the most important thing that we are talking about is the target vessel lesions. If you have very tight lesion, like 80–90%, you got an excellent patency. But if you go to the moderate lesion, 50–60%, you got a string sign, you got a competitive flow, some of the graft can get occluded. So endoscopic or open for radial artery harvest, Professor Tatoulis has already mentioned that. There's not much different. This is between open and the radial artery. The only difference is probably the cosmetic, the wound problems. That is different. Has the endoscopic is much better on this part. But Cordino recently has cautioned that open and endoscopic radial harvest, it found out that open radial artery harvesting is less trauma to the endothelial function than the endoscopic harvest. That is a caution for us. What about the long term after 20 years? This is the paper from Australia. You see that when we take out one radial artery, what happened to the ulnar arteries? Does that cause any problem at all? It doesn't seem to make any difference after 20 years. So it's very safe to take the radial artery off after you have carefully investigated that patient beforehand. So no different in total arm flow after 22 years. So radial artery is probably the second best conduit if you have patient obese, diabetic, you are reluctant to use the intrathoracic artery, maybe radial artery is the good choice. I think I'm not going to repeat what Professor Tatoulis has already talked about. Gastroepiploic artery, Professor Asai has already talked about that. And I just stress on non-skeletonized and skeletonized. You see the difference between skeletonized and non-skeletonized. The skeletonized has much better patency rate over like 8 or 10 years times. So how many arterial graft? Is 2 graft better than 1? Is 3 graft better than 2? Angelini's group did not show any difference between if you add the third arterial graft to the bilateral mammary arteries. But in the Americans group did not still say that the third artery has a better outcome than two arteries. But if you look at the gap, you know, the advantages of between 1 to 2, there's a significant gap. But between 2 and 3, the gap is very narrow. So that does not really, that means that the third graft has an advantage, but does not really have a very significant advantage over the bilateral mammary arteries. Saphenous vein graft is another one that we all talk about. It's Achilles heel of the coronary artery bypass because it has a poor patency rate from Cleveland Clinic's paper like almost more than 20, 30 years ago. Right now we found out that if you use no-touch technique, it is much better over, this is the 16 years result. It is more than 80% patency rate at 16 years. It is very promising, but that is the only single institute report. And why is it that? The reason behind this is probably because we have damaged the vein when we dissect it out. We do the dissection, we do the vein distension, and we put the vein into the high pressure system. And it all caused damage to the intima and eventually caused atherosclerosis and graft failure eventually. And currently there is an ongoing randomized study between no-touch technique and the open conventional techniques. At least at first year, there is no inferiority of the no-touch technique to the conventional technique. We still have to see what is the long-term result. And I'm not going to talk about it because time is running out. This is the external support on the vein. It seems that after 5 years, patency rate is pretty good with there is no atherosclerotic change in the intima at all because it has changed the mobilization of the mesothelium cells. What about the endoscopic and the open saphenous vein techniques, which is better? Earlier year in 2009, there is a significant difference between endoscopic and the saphenous vein and open technique. It seems that endoscopic has damaged the saphenous vein. And it is advised that maybe endoscopic vein harvest is not a very good idea for a long-term result. But the new study from the regroup trial found out that the endoscopic and open techniques after 10, 13 years, there's no difference in the endpoint at all. The only difference is the leg wound infection, which is much less with endoscopic harvest. So with all this knowledge in your hands with different kind of conduit, how to select the conduit? I think it depends on 3 factors. The surgeon's factor, if you have a good skill in arterial graft, small vessels, I think that the skill, you have to look at your skill first. The second thing is the patient's factor. Is there any problem? This patient is diabetic, patient is extremely obese, what is a life expectancy, what is a target coronary artery, and this all will dictate which type of the conduit you are going to use. and also the emergency or elective situation, which you want to get the patient off the table as fast as possible. You might not waste your time to do the all arterial graft. And there are different choices of total arterial coronary artery bypass, but I think we always have to remember that the left side for the arterial graft, there is competitive flow. If you want to make sure that the native lesion is more than 70%. The right side, you probably need more than 90% before you use the arterial graft. And there are different choices you can make. You know, the problem with the coronary artery disease, the result is there are so many combinations. There is no single or 1-2 combination. Each surgeon has his own recipe. So they are not completely different. That's why it's very difficult to judge which technique is better than which technique, which conduit is better than the other conduit. It depends on what the situation. I think you need to tailor your conduit towards the patients and also the coronary lesion. And this is probably Dr. Guardino's diagram on how to use the second target vessels. Not the first target, the second target vessel. If you use elective coronary artery bypass, if there is no contraindication for RA or GEA harvesting at all, no major risk factor, you go target vessel more than 70%, you use ITA or RA for the left side. If it is inferior wall, you should use the radial artery, or if the lesion is less than 90%, 70% on the right side, you should go for saphenous vein graft. If there is a major risk factor, maybe you should use something else like radial instead of mammary artery. And I think the degree of target vessel disease is the one that dictates whether you are going to use the saphenous vein or use radial artery or use the other graft. I think I'm gonna end right here. Thank you very much.
Dr. Weerachai summarized the whole session. Please go ahead.
Thanks, Weerachai. I think you sold yourself short. That was an excellent presentation. Just a few thought processes. We talk about sternal wound infection and bilateral mammaries, and this is not a forum and you want to get up and say it's routine, but bilateral mammaries is pretty much routine in my practice, in any patient, because I plate sternums, and I think that's another factor that probably comes in sternal wound infections. And of course, then it opens a whole bag of worms, what is deep and what is superficial. But I can tell you in all my group of patients, I've had not a medial stenitis. And I think plating is really important in getting complete fixation and no movement, coupled with skeletonization of the mammary. So I think that's something we have to bear in mind. But there's no doubt skeletonization of whatever format and Y graft works extremely well for those patients. But just to put it the other way around, nobody in this meeting has alluded to a paper by Jim's colleague in Melbourne that was very controversial at the European meeting a few years ago, where he looked at the addition of a vein in coronary surgery and found the adverse effects of vein grafts in patients and long-term outcomes. For some reason, we're not going to that paper. I mean, I found the statistics rather difficult to understand, to be honest. Maybe I'm just a bit dumb, but certainly, Alistair did demonstrate that adding a vein graft in patients can actually have an adverse outcome in long-term survival.
I think, thank you for reminding us on that. I think it's a very worrisome, statistic that comes out that, you add saphenous vein graft up, it is a negative on the patient itself. I think one thing is at that time, the saphenous vein graft is harvested by totally skeletonized vein. Maybe we don't know if you use the no-touch technique, is there gonna different impact on the survival or not?
Good morning. So, sorry, just one question. We're speaking about the benefits of the skeletizations of mammary arteries. Do you always consider not to cut the mammary vein when you do that?
Yeah, we try to not to damage the mammary vein, but
is it an important point?
We have to injure it. It's not always.
It's not easy always.
It's not easy to avoid that big, mammary vein sometimes.
But do you think there is an importance for the benefit of the skeletization?
I believe so.
Thank you.
Dr. Werechai,
Yes, sir.
Recent art trial, we were all surprised with the crossover. So many. That might be indicating the skeletonization of two mammary, or even single. It's not as easy as we think in a standard situation. So technical difficulty might not be too much underestimated. That's my personal opinion. Okay, there is some comment.
Go ahead.
Just the benefit of the Vericue system or Medistem, just talking about skeletonization, I've had 3 patients where the flows down the lemur graft looked really unusually bad with a high PI. And then I looked back and found that the 2 veins on each side of the mammary on the left-hand side, there was a crossover of the vein on the outer side to the inside. And once I divided that vein, I had normal flow. So just be aware in skeletonization sometimes, if the vein does cross under the mammary, it could actually affect your flow down the graft.
Yeah, thank you.
Ajahn Rechai, I would like to ask about the futures of selecting the conduit that is good for patients. Like mitral valve repair in degenerative, we have 5 or 6 standard repair techniques. That is better than you replace the valve. But now we come to the coronary artery surgery. We know now that most of the cases have the profit from arterial graft. And now I think in Thailand maybe we don't know how much doctors in Thailand use arterial graft right now. And like you present in your slide, that there's an algorithm, just like the way to choose the techniques into the mitral valve repair. But is it possible that in the near future that we can use that as a template to suggest surgeons to use this kind of algorithm? Because right now, even in each institution, surgeons have a different opinion, always. Like we do this triple vessel disease, 1 or 2 different doctors have a different opinion. And for the sake of the benefit of the patient, you know that why don't you just use 2 arterial graft, but something, no, I just want to do 1 MA and the rest is the vein graft. Do you think that is going to be the future, that the algorithm like this is real and it should be focused on like the mitral valve repair strategy? Thank you.
I think it will be, you will notice that as a, either what kind of surgery is, cardiac surgery is one of them. When some people publish something that is good, everyone will use that kind of procedures. Let's say all arterial graft is good, everyone is trying to do all arterial graft without realizing that, there is a problem with it if you don't use it properly. If, let's say, at the beginning, why do we have a lots of string sign? Why do we have the first radial artery doesn't work? Carpentier has published paper the first year, and he has to retract that paper the next year because, the thing that we do not know what we should not do. That's the reason right now we have a lot of data of each conduit, which to do or not to do for those kind of conduit. I think it eventually is going to make an algorithm where there will be a limitation on what to use and what not to use. Right? In the past, we think that, well, right mammary artery should go to the right, and it doesn't work that way because if you have a big moderate lesion on the right, it is much worse than the left system. That's why, we are starting thinking about, instead of using mammary to the right, we're trying to use some other conduit like vein graft or, try to look at the lesion-specific target vessel to choose which conduit to use. But I think there will be a rules and regulation of how to use conduit for each conduit. We all learn from our mistake.
Okay, Dr. Werechai. This is a rare area, still guideline. Which one should be done this way? There's not only one way doing it. So we still need to have more multiple data.
Right.
And also I think technical factor is very important. So I think it's this discussion to be continued for the next meeting. We'll conclude this session. Thank you very much for active attendance. Thank you very much.